Hello and welcome to the PEDS GI Academy. My name is Jonathan Gisser. I'm a pediatric gastroenterologist at Nationwide Children's Hospital. Today we're going to be talking about pediatric video capsule endoscopy. So our overview is as follows. What is capsule endoscopy? What are the indications for capsule endoscopy? What are the risks, limitations, and contraindications of capsule endoscopy? How to interpret capsule endoscopy? And we will also look at selected findings in capsule endoscopy. So first of all, what is capsule endoscopy? Video capsule endoscopy, also known as wireless capsule endoscopy, consists of a pill-sized camera with an internal power supply and a light source that can be swallowed by the patient or placed in the small intestine with an endoscope. The capsule captures images approximately every 2 to 6 seconds and transmits these images to sensors that are worn by the patient. The stored images are then uploaded to a computer for viewing with specialized software. The physician at a later time reviews all the images and identifies any pathology. There are multiple different types of capsules. Some are designed for use in the upper gastrointestinal tract. Some are designed for use in the small bowel, and some can capture images in the small bowel and the colon. Today we will be talking mainly about capsules used for the small bowel. In preparation for a video capsule endoscopy, a patient is made NPO. The sensors are placed on their abdomen to receive images and track the location of the capsule. The patient is allowed to eat about 2 hours after capsule ingestion, and the study is complete about 8 to 10 hours later. The stored images are then retrieved for upload, and the patient, hopefully, eventually passes the capsule. So what are the indications for capsule endoscopy? Well, with conventional endoscopy, such as upper endoscopy, the upper endoscope can only reach about the second portion of the duodenum. If one wants to interrogate the lower GI tract, the colonoscope can interrogate up to the terminal ileum. However, that leaves a lot of small bowel in between. To interrogate the small bowel better, one can use double balloon enteroscopy, GI imaging, fluoroscopy or angiography, nuclear scintigraphy, or intraoperative enteroscopy. However, video capsule endoscopy is sometimes used for its advantages over these other procedures. So some of the advantages of video capsule endoscopy include that, well, first of all, you can interrogate the small bowel. Second of all, it's considered a non-invasive test. It has greater sensitivity for bleeding and flat lesions than most radiographic tests. There's no radiation involved, and most importantly, if one were to proceed with double balloon enteroscopy or surgery to investigate the lesion, the video capsule endoscopy can provide the surgeon or the endoscopist with much needed additional information about the location of the lesion. So the indications for small bowel video capsule endoscopy include where upper endoscopy and colonoscopy have failed to secure a diagnosis and there is a concern for Crohn's disease or obscure gastrointestinal bleeding. Small bowel video capsule endoscopy is also used for celiac disease, polyposis syndromes, failure to thrive or growth failure when the diagnosis is unclear. The two main indications, though, are Crohn's disease and obscure gastrointestinal bleeding. So a little word about obscure gastrointestinal bleeding and the definition. Obscure gastrointestinal bleeding is unexplained iron deficiency anemia, overt or occult rectal bleeding without a source on conventional endoscopy. Just a reminder, overt rectal bleeding is hematochezia and melena. Some causes of obscure GI bleeding include Crohn's disease, angioctasias or AV malformations, Meckel's diverticulum, non-steroidal anti-inflammatory drug enteropathy or NSAID enteropathy, small bowel tumors, and small bowel varices. A word about age and video capsule endoscopy. The most capsule manufacturers label their capsules down to 2 years of age. However, our center and others have experience with capsules in children as young as 1 year old, and there is a small literature on that topic as well. Below the age of approximately 8 years old, endoscopic placement of the capsule is indicated because the child cannot swallow a capsule of that size. Above the age of 8, the capsule can be swallowed. So what are the risks of capsule endoscopy? The main risk of capsule endoscopy includes capsule retention. The risk of this is about 1 to 5%, depending on the indication for the capsule in the first place. Here are 2 images of capsules that were lodged in the GI tract, both indicated by the arrow. In the case of capsule retention, sometimes the capsule needs to be retrieved either with balloon enteroscopy or surgically. In order to prevent capsule retention, sometimes a patency capsule is employed. The patency capsule is a radio-opaque dummy capsule that is the same size as the video capsule, but were it to get lodged in the body, it can degrade if it fails to pass. It can be administered as a sort of test run to assess the valve patency prior to doing the actual video capsule endoscopy. Here's a picture of the degraded capsule. Another risk of video capsule endoscopy is capsule aspiration. This is a very rare occurrence, and there is not a lot of data on this phenomenon in children. However, these images show, the image on the left is a picture of the bronchial tree from a video capsule, and you can see the bifurcation, which one would not see in the normal GI tract. And the image on the right is a chest radiograph with the capsule in the left mainstem bronchus. Contraindications to video capsule endoscopy include bowel obstruction and fistula because of the increased risk of capsule retention, pseudo-obstruction, again because of risk of capsule retention and failure of the capsule to pass, swallowing disorder when the capsule is swallowed. If a patient has a swallowing disorder, one can still administer the capsule via endoscopic technique. And although implantable cardiac device used to be a contraindication, this is less clear now, and it is being used in patients who have implantable cardiac devices. Some limitations of capsule endoscopy. The capsule can only provide a view of the mucosa, and it cannot provide any transmural imaging. One can not obtain biopsies with the capsule and can only be used for, the capsule can only be used for diagnostic purposes. You can't direct the capsule or steer the capsule in any way or adjust the rate at which it passes. And there is a considerable amount of time needed to interpret a capsule, as we will mention in a few moments. So how to interpret capsule endoscopy? There are more than 50,000 images obtained in a single capsule study. In some cases, widespread disease is found, and the pathology is readily noticed. However, sometimes a small bowel may be normal. A normal video capsule endoscopy study is very difficult to read because it takes a tremendous amount of patience. Sometimes small isolated lesions are encountered and every image has to be examined. In fact, some lesions may only be seen on one image. So interpretation requires patience and vigilance. The optimal conditions for reading a capsule endoscopy include a quiet room, subdued lighting, a large computer monitor, a well-rested and well-fed examiner. The examiner should be familiar with the patient medical history and should view the capsule study at less than 15 frames per second. If the study is viewed too quickly, pathology may be missed. Now we will look at some select findings in capsule endoscopy. So here is an image of the small bowel that one might think contains an ulcer. And I will enlarge this area over here that is denoted by the arrow. It looks like an indented or eroded region with some erythema around it. However, when one looks at the images before and after this image, one notes that that is not an ulcer, but rather passing debris, or debris that's passing through the GI tract, and it's not fixed in one place. So an important lesson is that one should view a suspected lesion in the context of the images that come before and after it. Here's another picture with a seeming pathology denoted by the arrow. Again, is this an ulcer or an erosion? Actually, if you look at the image that's immediately prior to it, you will see the same fold of the intestine that does not have that lesion. So what is this lesion? This is the parting of the villi by the dome of the capsule. So another take-home lesson is that the presence of the capsule can cause artifactual distortion of its surroundings. Now here was an unusual finding that the practitioner thought was possibly a polyp or an unusual tumor. However, this is the duodenal papilla. And here's a textbook photo juxtaposed next to it, and note the similarity. So the take-home lesson from this is that it's very important to be familiar with normal capsule endoscopic findings, and it's mandatory for discerning it from pathologic findings. It's also important to be aware of where in the GI tract an image was obtained. This particular image was obtained in the duodenum. In this image, one sees a large mass denoted by the circle protruding into the lumen. However, this mass was then later interpreted on another image as possibly an intussusception, a loop of bowel intussuscepting into another loop of bowel. However, going back a few more images, one sees the pylorus viewed from the stomach. And what this actually is a view of the pylorus from the duodenum. Most endoscopists can recognize a pylorus viewed from the stomach because that is the standard approach where one sees the pylorus. However, this is called the dark side of the pylorus because it's viewed from the duodenum and not from the stomach. So the lesson here is that the capsule is able to tumble in any direction that it chooses and can face any direction as it courses through the GI tract. So one can expect to see normal structures from different angles than one would see during a conventional endoscopy. Now here are two pictures of what seems to be normal mucosa. In fact, this is abnormal because these two images were taken, this one and this one, the one on the left and the right, were taken 15 minutes apart. And as you can see from this time-lapse video, the capsule is not moving at all. So while the mucosa looks normal, there may be a dysmotility. As you can see, 15 minutes apart. So the lesson here is, although it's important to look at individual images, one should also scroll through the images at different speeds because that can sometimes yield additional information, such as the motility of the GI tract. Now we'll look at some cases. So this is a 12-year-old boy who has abdominal pain, diarrhea, and weight loss, elevated sed rate, and mild anemia. Taken together, this is concerning for inflammatory bowel disease. However, his upper endoscopy and colonoscopy were grossly and histologically normal. So the image on the left shows a normal small bowel, and the image on the right, for comparison, shows small bowel from a patient with Crohn's disease. You can see erythema and purulence and ulceration. So this occurred in the ileum, but proximal to where one can reach with a colonoscope. Case number 2 is a 5-year-old girl with painless rectal bleeding. She had a negative Meckel scan, and her colonoscopy revealed only old blood in the colon, but no source of bleeding was identified. So this turned out to be a Meckel's diverticulum. The Meckel scan, while a very good test for diagnosing Meckel's diverticulum, was negative in this case, a false negative. So what gives this away on this capsule endoscopic image is that there are 2 lumens denoted by the asterisks. One is the lumen of the diverticulum, and the other is the actual lumen, and also the ulceration around the diverticulum lumen. So this is a Meckel's diverticulum. Case number 3 is a 3-year-old girl with Turner syndrome admitted for lower GI bleeding and iron deficiency anemia. On her upper endoscopy, Meckel scan, and CT angiography were all normal. The colonoscopy was notable only for prominent vessels throughout the colon. So here were images, select images from her small bowel video capsule endoscopy. And as you can see, there are multiple angioctasias, little bleeding lesions throughout her small bowel. Case number 4 is a 4-year-old boy with painless rectal bleeding and a family history of polyps. His upper endoscopy and colonoscopy, Meckel scan, small bowel follow-through, and CT abdomen were all non-revealing. However, on video capsule endoscopy, he was noted to have this structure. This is a polyp. The arrow denotes the stalk of the polyp, of the pedunculated polyp. Here is another polyp in his GI tract. Notice the multilobular appearance, denoted by the arrows. So, some take-home points of a video capsule endoscopy. So, video capsule endoscopy is useful for obscure GI bleeding, Crohn's disease, and other conditions where upper endoscopy and colonoscopy have failed to secure a diagnosis. Patients' vigilance and experience are required for optimal capsule interpretation. Capsule retention is the main complication of video capsule endoscopy. And here are some recommended reading. If you are going to do a video capsule endoscopy interpretation, you should have the first book at your side at all times. The second reference talks about pediatric video capsule endoscopy. Sorry, the third reference talks about pediatric video capsule endoscopy, and the second reference talks about guides for how to interpret these studies. Thank you all for joining me, and have a wonderful day.